Good morning, everyone. My name is David Patrician, a third-year psychiatry resident at the University of Saskatchewan. Today I thought it'd be useful to talk about depressive disorders. I expect this presentation to take between 75 and 90 minutes. So let's begin. These are the objectives for today's presentation. I won't read them in entirety, but essentially I hope that by the end of this presentation you will be familiar with the essential feature of each of these disorders, their prevalence and risk factors, differential diagnosis, and some elements of their treatment. Now, the depressive disorders chapter has a number of specifiers. We will discuss these in the final part of the presentation. You may be asking yourselves, David, how are we going to be able to remember all of these details? Through a series of clinical cases, that's how. So let's begin with case 1. Jane is a 12-year-old girl referred to you for assessment of outbursts. On assessment, she is overtly irritable, and you soon learn that she has a fiery temper. Her mother apologizes for Jane's behavior and provides you with additional history. You learn that since the age of 8, Jane has been exhibiting episodes of verbal and/or physical aggression in response to seemingly benign circumstances. Her mother describes an example of the most recent episode, during which Jane's favorite television program was delayed by an hour due to daylight savings time. Jane began screaming and punching the television, eventually destroying it. These outbursts occur 3 to 4 times per week. It's getting so we are worried to take her to school. Doesn't matter where she is, outbursts can occur at any time. And so, keeping in mind this is a presentation on depressive disorders, what is your preferred diagnosis? This is a case of disruptive mood dysregulation disorder, the essential feature of which is chronic and persistent severe irritability. This is a disorder of childhood onset, and symptoms must be present between the ages of 7 and 10 and for at least 12 months. So I strongly dislike the verbose DSM-5 TR criteria. So to shorten it a bit, I use a series of mnemonics. They are CPS investigation, stop, die, and pain. I'll expand on each of them in turn. So CPS investigation stands for the essential feature, which is chronic and persistent severe irritability. STOP stands for severe temper outbursts out of proportion. DI, or DI3, stands for developmentally inappropriate and 3 times per week. And pain stands for persistent anger and irritability, which are notable by others. So back to case 1. Jane's mother is relieved that there's a name for the disorder afflicting her child and asks you to comment on the following. How prevalent is disruptive mood dysregulation disorder? Is it more common in male or female children? What is the typical age of onset for DMDD? What are the risk factors for DMDD? The 6 to 12 month prevalence estimates for DMDD are between 2 to 5%. Males are more commonly impacted, as are school-age children in comparison to adolescents. In agreement with the diagnostic criteria, onset occurs before the age of 10. Genetic and biological risk factors for this disorder include family history. Temperamental risk factors include irritability, face emotion and labeling deficits, decision-making problems, and cognitive control issues. Information processing deficits and reduced attention in response to emotional stimuli are also frequently noted. And environmental risk factors include exposure to psychological abuse, neglect, parental psychiatric disorders, lower parental education, being brought up in a single-parent household, exposure to early trauma, death experiences at an early age, death of a parent, parental grief, divorce, and malnutrition. So satisfied with your knowledge of the epidemiology of this disorder, Jane's mother asks you how sure you are that it is disruptive mood dysregulation disorder and not another mental disorder. What is the differential diagnosis for DMDD? Here is the differential diagnosis for DMDD according to DSM-5 TR. Next, let's take each of these in turn and see how to distinguish them from DMDD. How does DMDD differ from bipolar diatheses? The central feature differentiating disruptive mood dysregulation disorder and bipolar disorders in children involves a longitudinal course of the core symptoms. In children, as in adults, bipolar I disorder and bipolar II disorder manifest as an episodic illness with discrete episodes of mood perturbation that can be differentiated from the child's typical presentation. The mood perturbation that occurs during a manic episode is distinctly different from the child's usual mood. In addition, during a manic episode, the change in mood must be accompanied by the onset or worsening of associative cognitive, behavioral, and physical symptoms, for example, distractibility and increased goal-directed activity, which are also present to a degree that is distinctly different from the child's usual baseline. Thus, in the case of a manic episode, parents, and depending on the developmental level, children, should be able to identify a distinct time period during which the child's mood and behavior were markedly different from usual. In contrast, the irritability of disruptive mood dysregulation disorder is persistent and is present over many months. While it may wax and wane to a certain degree, severe irritability is characteristic of the child with disruptive mood dysregulation disorder. Thus, while bipolar disorders are episodic conditions, DMDD is not. In fact, the diagnosis of DMDD cannot be assigned to a child who has ever experienced a full-duration hypomanic or manic episode, irritable or euphoric, or who has ever had a manic or hypomanic episode lasting more than 1 day. Another central differentiating feature between bipolar disorders and DMDD is the presence of elevated or expansive mood and grandiosities. These symptoms are common features of mania, but are not characteristic of DMDD. Okay, so how does DMDD differ from oppositional defiant disorder? While symptoms of oppositional defiant disorder typically do occur in children with DMDD, mood symptoms of DMDD are relatively rare in children with oppositional defiant disorder. The key features that warrant the diagnosis of DMDD in children whose symptoms also meet criteria for oppositional defiant disorder are the presence of severe and frequently recurrent outbursts and a persistent disruption in mood between outbursts. In addition, the diagnosis of DMDD requires severe impairment in at least one setting, that is home, school, or among peers, and mild to moderate impairment in a second setting. For this reason, while most children whose symptoms meet criteria for DMDD will also have a presentation that meets criteria for oppositional defiant disorder, the reverse is not the case. That is, in only approximately 15% of individuals with oppositional defiant disorder will criteria for DMDD be met. Moreover, even for children in whom criteria for both disorders are met, only the diagnosis of DMDD should be made. Finally, both the prominent mood symptoms in DMDD and the high risk for depressive and anxiety disorders in follow-up studies justify placement of DMDD among the depressive disorders in DSM-5. This reflects the more prominent mood component among individuals with disruptive mood dysregulation disorder as compared with individuals with oppositional defiant disorder. Nevertheless, it also should be noted that DMDD appears to carry a high risk for behavioral problems as well as mood problems. So how do we differentiate ADHD, MDD, anxiety disorders, and autism spectrum disorder from DMDD? As an aside, I'm not sure why DSM-5-TR included this as one differential diagnosis. But let's move on. First off, it's important to note that ADHD and DMDD can occur comorbidly. However, children whose irritability is present only in the context of a major depressive episode or persistent depressive disorder should receive one of these diagnoses rather than DMDD. Children whose irritability is manifest only in the context of an exacerbation of an anxiety disorder should receive the diagnosis of the relevant anxiety disorder rather than DMDD. Additionally, children with autism spectrum disorder frequently present with temper outbursts when, for example, routines are disturbed. In such a case, severe temper outbursts will be considered secondary to autism spectrum disorder and should not be diagnosed with DMDD. And finally, how does DMDD differ from intermittent explosive disorder? Children with symptoms suggestive of intermittent explosive disorder present with instances of severe temper outbursts, much like children with DMDD. However, unlike DMDD, intermittent explosive disorder does not require the individual's mood to be persistently irritable or angry between outbursts. In addition, a diagnosis of intermittent explosive disorder involving verbal aggression or physical aggression that does not result in damage to property or physical injury to animals or other individuals, occurring at least twice weekly, can be made after only 3 months of symptoms, in contrast to the 12-month requirement for DMDD. Thus, these two diagnoses should not be made in the same child. For children with outbursts and intercurrent persistent irritability, only the diagnosis of DMDD should be made. "Please, doctor," Jane's mother pleads. "Tell me how we are going to make her better." With safety in mind, how would you proceed with treatment in the case of disruptive mood dysregulation disorder? Unfortunately, there are limited systematic treatment data for new disorders such as disruptive mood dysregulation disorder. In terms of pharmacotherapy, treatments used in DMDD aim to target specific symptoms of this disorder. In keeping with that premise, we use stimulants for impulsivity and behavioral concerns, mood stabilizers to address dysregulation, anxiolytics for anxious symptoms, and even antipsychotics. Psychotherapy used in the treatment of DMDD focuses on responding to frustration and anger more effectively, and developing the person's ability to deal with social and emotional aspects of living. In conclusion, Jane's mother thanks you for your time and expertise in addressing her daughter's concern. As you near the end of the appointment, Jane becomes restless and starts kicking at her mother's feet. She begins swearing loudly, and you very much hope that they will make it home sooner than later. The last you hear as the mother and daughter meander down the hallway is, "I don't want McDonald's, I want Burger King." You close the door to your office and start your dictation. Now on to case 2. You were a psychiatry resident on call in the emergency department one night. You receive a consult with a chief concern of no motivation. You decide to see the patient, and the clerk on call with you tags along. Upon meeting the patient, he relays the following history. "I'm just so lazy, doc. I can't do anything anymore. For the past few weeks, it's like all I do is lay in bed all day. I used to enjoy watching YouTube, but now, not even that seems interesting to me. Not that I could focus on what I'm watching. When I'm not thinking about how lazy I am, I'm sleeping. I've got no energy for anything. Yeah, it's like all I do is lay in bed, watch TV, and sleep. I'm worthless. What's the point of me? What's the point of existing anymore? Maybe I would be better off dead." Now, keeping in mind that this is a presentation of depressive disorders, what is your preferred diagnosis for this case? You may have guessed it. This is bread and butter psychiatry. Major depressive disorder. The essential feature of major depressive disorder is a period of at least 2 weeks during which time the patient presents with depressed mood or loss of interest or pleasure in nearly all activities. It's important to note that for children, it can be low mood, anhedonia, and additionally, irritable mood. On top of this, patients need to have 4 of the M-SIGI-CAP symptoms occurring over that same time period. There are a number of specifiers that can be applied to MDD. This is just a preview for the final section of the presentation. You complete your history on this patient and discuss the case with the clinical clerk. They are impressed with your history-taking skills and with your ability to formulate a preferred diagnosis. They ask you the following questions about the epidemiology of major depressive disorder. What is the prevalence of major depressive disorder? When does incidence peak for major depressive disorder? Is major depressive disorder more common in males or females? Is major depressive disorder more common in younger or older people? What are the risk factors for major depressive disorder? And what are the risk factors for chronic or recurrent episodes of major depressive disorder? The 12-month prevalence of major depressive disorder is 7%, although this number varies depending on the source you look at. It peaks in the 20s and is more common in females than males at a rate of approximately 2 to 1. It is also more common in individuals between the ages of 18 to 29 compared to older individuals. In the elderly, the incidence is approximately 1%. Genetic risk factors include family history and female sex. For those with first-degree relatives diagnosed with major depressive disorder, the risk is 2 to 4 times higher than the general population. Temperamental traits that increase the risk of developing major depressive disorder include neuroticism, and environmental risk factors include exposure to adverse childhood events and exposure to stressful events in general, as well as having a chronic or disabling medical condition. Here I've listed 10 risk factors related to prognosis, either chronic or recurrent major depressive episodes. These include earlier age of onset, greater number of previous episodes, severity of initial episode, disruptions of the sleep-wake cycle, presence of comorbid psychopathology, family history of psychiatric illness, presence of negative cognitions, high neuroticism, poor social support, and stressful life events. Before we move on to differential diagnosis, I think it's important to emphasize the difference between grief and MDD. In grief, the predominant affect is feelings of emptiness and loss. Eventually, the individual experiences pangs of grief from reminders of the loss. Comparatively, in major depressive disorder, there is persistently depressed mood and inability to anticipate happiness or pleasure. The persistence is a key differentiating factor. Having answered many questions about major depressive disorder, you decide to turn the questioning to your medical student colleague and ask the monumental question, what is the differential diagnosis for major depressive disorder? This is the rather lengthy differential diagnosis for major depressive disorder. I wouldn't be surprised if you tuned out partway through this discussion. Let's start by differentiating between major depressive disorder and manic episodes with irritable mood or mixed features. Major depressive episodes with prominent irritable mood may be difficult to distinguish from manic episodes with irritable mood or with mixed features. This distinction requires a careful clinical evaluation of the presence of sufficient manic symptoms to meet threshold criteria. That is 3 if mood is manic, 4 if mood is irritable but not manic. What about bipolar diatheses? All that need be considered is whether there has ever been evidence of a hypomanic or manic episode. In situations where criteria for neither a hypomanic or manic episode has been met, but where manic symptoms have been endorsed, the diagnosis of another specified bipolar and related disorder may be given. How can we tell whether depressive disorder is major depressive disorder or whether depressive symptoms are due to another medical condition? A diagnosis of depressive disorder due to another medical condition requires the presence of an etiological medical condition. Major depressive disorder is not diagnosed if the major depressive-like episodes are all attributable to the direct pathophysiological consequence of a specific medical condition, such as multiple sclerosis, stroke, or hypothyroidism. In a similar vein, how do we differentiate between depressive symptoms in major depressive disorder and depressive symptoms caused by a substance or medication taken by your patient? Substance and medication-induced depressive disorder is distinguished from major depressive disorder by the fact that a substance, for example, a drug of abuse, a medication, or a toxin, appears to be etiologically related to the mood disturbance. For example, depressed mood that occurs only in the context of withdrawal from cocaine will be diagnosed as cocaine-induced depressive disorder. Now let's see how major depressive disorder differs from persistent depressive disorder, that is, chronic depression. Surprisingly, these two diagnoses are not mutually exclusive. Persistent depressive disorder is characterized by depressed mood more days than not for at least 2 years. If criteria are met for both major depressive disorder and persistent depressive disorder, both can be diagnosed. Okay, so how does major depressive disorder differ from premenstrual dysphoric disorder? The primary differentiating factor is the relationship between the symptoms and menses. Recall, premenstrual dysphoric disorder is characterized by dysphoric mood that is present in the final week before the onset of menses, that starts to improve within a few days after the onset of menses, and that becomes minimal or absent in the week post-menses. By contrast, the episodes of major depressive disorder are not temporally connected to the menstrual cycle. Now let's throw back to DMDD and see again how major depressive disorder differs from this condition. As you may recall, disruptive mood dysregulation disorder is characterized by severe, recurrent temper outbursts manifested verbally and or behaviorally, accompanied by persistent or labile mood most of the day, nearly every day, in between the outbursts. In contrast, in major depressive disorder, irritability is confined to the major depressive episodes. Here's another one of these massive combination differentials of the DSM-5-TR, but essentially, all this one is asking you is for you to differentiate the conditions that present with the symptoms of psychosis from MDD with psychotic features. So let's differentiate. Depressive symptoms may be present during schizophrenia, delusional disorder, schizophreniform disorder, or other specified or unspecified schizophrenia spectrum and other psychotic disorders. Most commonly, such depressive symptoms can be considered associated features of these disorders that do not merit a separate diagnosis. However, when the depressive symptoms meet full criteria for a major depressive episode, a diagnosis of other specified depressive disorder may be made in addition to the diagnosis of the psychotic disorder. Depressive symptoms may be... Further to our differentiation between major depressive disorder and psychotic disorders, let's differentiate between schizoaffective disorder and major depressive disorder, with psychotic features. Schizoaffective disorder differs from major depressive disorder with psychotic features by the requirement that in schizoaffective disorder, delusions or hallucinations are present for at least 2 weeks in the absence of a major depressive episode. Now, how about differentiating major depressive disorder from ADHD? Distractibility and low frustration tolerance can occur in both attention deficit hyperactivity disorder and a major depressive episode. If the criteria are met for both ADHD and major depressive disorder, ADHD may be diagnosed in addition to the mood disorder. However, the clinician must be cautious not to overdiagnose a major depressive episode in children with ADHD, whose disturbance in mood is characterized by irritability rather than by sadness or loss of interest. How do we differentiate between adjustment disorder with depressed mood and major depressive disorder? A major depressive episode that occurs in response to a psychosocial stressor is distinguished from adjustment disorder with depressed mood by the fact that the full criteria for a major depressive episode are not met in adjustment disorder. Next, let's expand on our earlier conversation related to bereavement and grief. Bereavement is the experience of losing a loved one to death. It generally triggers a grief response that may be intense and may involve many features that overlap with symptoms characteristic of a major depressive episode, such as sadness, difficulty sleeping, and poor concentration. Features that help differentiate a bereavement-related grief response from a major depressive episode include the following. The predominant affects in grief are feelings of emptiness and loss, whereas in major depressive episode, they are persistent depressed mood and a diminished ability to experience pleasure. Moreover, the dysphoric mood of grief is likely to decrease in intensity over days to weeks and occurs in waves that tend to be associated with thoughts or reminders of the deceased, whereas a depressed mood in a major depressive episode is more persistent and not tied to specific thoughts or preoccupations. It is important to note that in a vulnerable individual, for example, someone with a past history of major depressive disorder, bereavement may trigger not only a grief response, but also the development of an episode of depression or the worsening of an existing episode. And lastly, let's talk about sadness. Periods of sadness are inherent aspects of the human experience. These periods should not be diagnosed as a major depressive episode unless criteria are met for severity, that is, 5 out of 9 symptoms, duration, that is, most of the day, nearly every day for at least 2 weeks, and clinically significant distress or impairment. The diagnosis of other specified depressive disorder may be appropriate for presentations of depressed mood with clinically significant impairment that do not meet criteria for duration or severity. Back to case 2. You are certain that you've scared the clerk out of ever wanting to pursue a career in psychiatry, but decide to continue pressing them for answers. Now you turn your attention to treatment. You ask them, with safety in mind, how would you proceed with treatment for major depressive disorder? Treatments for major depressive disorder are broken into 2 phases, pharmacotherapy and psychotherapy. This table is a summary of the CAN-MAC guidelines for the pharmacological treatment of depression. As you can see, there are a number of drugs listed here, but I'll focus on the first-line medications. Now, all of the medications are noted on the slide, but I'm only going to read out the ones that are available in Canada. These are, in alphabetical order, bupropion, citalopram, desvenlafaxine, duloxetine, escitalopram, fluoxetine, fluvoxamine, mirtazapine, and paroxetine. And although this table is necessary for studying purposes, I prefer to use this table, also from CAN-MAT, which notes antidepressants with superior efficacy based on meta-analyses. My favorite part about this table is that it can easily be made into a mnemonic, EMS-VAC. This stands for escitalopram, mirtazapine, sertraline, venlafaxine, agomelatine, and citalopram. What about psychotherapy for major depressive disorder? Well, CAN-MAT was good enough to put together a summary table on this as well. Here we can see that first-line psychotherapies for acute major depressive disorder include CBT, IPT, and behavioral activation. For maintenance, the first line includes CBT and mindfulness-based CBT. The second table is one to come back to later. It speaks to some of the nuances of psychotherapy when other conditions are comorbid with major depressive disorder. So to conclude case 2, you return to the patient after having discussed your plans for treatment. He is admitted voluntarily to the inpatient psychiatry unit and initiated on first-line pharmacotherapy, with plans to pursue psychotherapy with CBT on an outpatient basis once stabilized. Here is case 3. You are an outpatient psychiatrist who is about to see Brianna, a 21-year-old woman, for the chief concern of depression. She tells you that for the better part of the past 3 years, she has been experiencing depression, feelings of hopelessness, and low self-esteem. She does not meet criteria for major depressive disorder, nor has she ever. Her developmental history was notable for parental loss following the death of her mother at age 11. She had neuroimaging, which the radiologist commented was grossly normal despite very minor abnormalities in the prefrontal cortex, anterior cingulate, amygdala, and hippocampus. Keeping in mind this is a presentation on depressive disorders, what is your preferred diagnosis? This is persistent depressive disorder, previously referred to as, and still sometimes called, dysthymia. The essential feature of this disorder is the presence of depressed mood most days, most of the time, for at least 2 years in adults, and at least 1 year in the child and adolescent population. Like MDD, kids might present with irritable mood instead of depressed mood. The main difference between major depressive disorder and persistent depressive disorder are length of illness and the number of symptoms required. These symptoms, in addition to depressed mood in adults and either depressed or irritable mood in youth, are remembered with the mnemonic CHEESE. This stands for poor concentration, hopelessness, poor energy, sleep disturbance, and low self-esteem. In certain cases, patients may have a major depressive episode during their course of persistent depressive disorder. If this occurs, the diagnosis remains persistent depressive disorder, but you can also diagnose major depressive disorder. Persistent depressive disorder has one unique specifier, which has to do with onset. Persistent depressive disorder is considered early onset if it occurs prior to the age of 21, and late onset if it occurs after the age of 21. You explain your preferred diagnosis to Brianna, who remains depressed but expresses some curiosity. She asks you the following questions regarding the epidemiology of this diagnosis. What is the prevalence of persistent depressive disorder? Is persistent depressive disorder more common in males or females? Is persistent depressive disorder more common in higher income or lower income countries? What is the typical age of onset of persistent depressive disorder? And what are the risk factors for persistent depressive disorder? The 12-month prevalence of persistent depressive disorder is 0.5%. Females are affected more commonly than males at a ratio of 1.5 to 1. It is more common in higher income countries and most often occurs in early life. Biological risk factors for this condition include having a first-degree relative with this disorder, and there have been abnormalities observed in the prefrontal cortex, anterior cingulate, amygdala, and hippocampus. There have also been abnormalities observed on polysomnography. Temperamental risk factors for this condition include neuroticism, poor global functioning, presence of anxiety disorders or chronic disorders, and borderline personality disorder, which is considered a robust risk factor. Environmental risk factors for this condition include early parental loss or separation and childhood adversity. Brianna asks, are you sure this is persistent depressive disorder? Is there anything else it could be? What is the differential diagnosis for persistent depressive disorder? So now let's work through the differential diagnosis for persistent depressive disorder. Let's start with the most obvious differential diagnosis, major depressive disorder. In comparison to individuals with major depressive disorder, those with persistent depressive disorder are at a higher risk for psychiatric comorbidity in general, and for anxiety disorders, substance use disorders, and personality disorders in particular. Early onset persistent depressive disorder is strongly associated with DSM-5-TR cluster B and C personality disorders. If there is a depressed mood for more days than not, plus 2 or more persistent depressive disorder criterion B symptoms for 2 years or more, then the diagnosis of persistent depressive disorder is made. If the symptom criteria are sufficient for a diagnosis of a major depressive episode at any time during this period, then the additional diagnosis of major depression should be made. The comorbid presence of major depressive episodes during this period should also be noted by assigning the appropriate course specifier to the persistent depressive disorder diagnosis as follows. If the individual's symptoms currently meet full criteria for a major depressive episode, and there have been periods of at least 8 weeks in at least the preceding 2 years with symptoms below the threshold for a major depressive episode, then the specifier with intermittent major depressive episodes with current episode would be assigned. If full criteria for a major depressive episode are not currently met, but there has been one or more major depressive episodes in at least the preceding 2 years, then the specifier with intermittent major depressive episodes without current episode is assigned. If a major depressive episode has persisted for at least a 2-year duration and remains present, then the specifier with persistent major depressive episode is used. If the individual has not experienced an episode of major depression in the last 2 years, then the specifier with pure dysthymic syndrome is used. What about other specified depressive disorder? A very limited number of individuals will have depressive symptoms that have persisted longer than 2 years, but that do not meet criteria for persistent depressive disorder. If full criteria for a major depressive episode have been met at some point during the current episode of illness, a diagnosis of major depressive disorder would apply. Otherwise, a diagnosis of other specified depressive disorder or unspecified depressive disorder should be given. How does persistent depressive disorder differ from bipolar diathesis? Well, this is fairly obvious. If there has ever been a history of a manic or hypomanic episode, the more appropriate diagnosis is either bipolar 1 or bipolar 2. Other specified bipolar disorder applies to individuals whose presentations include history of hypomanic episodes, along with a persistent depressive episode whose symptoms have never met criteria for a major depressive episode. Okay, that's fair. What about cyclothymic disorder? A diagnosis of cyclothymic disorder precludes the diagnosis of persistent depressive disorder. Thus, if during the period lasting at least 2 years of depressed mood for most of the day for more days than not, number 1, there are numerous periods with hypomanic symptoms that do not meet criteria for a hypomanic episode. Number 2, there have not been any symptom-free periods of more than 2 months at a time. And number 3, criteria have never been met for a major depressive, manic, or hypomanic episode. Then the diagnosis would be cyclothymic disorder instead of persistent depressive disorder. Let's talk about psychotic disorders next. Remember, depressive symptoms are a commonly associated feature of chronic psychotic disorders. For example, schizoaffective disorder, schizophrenia, and delusional disorder. A separate diagnosis of persistent depressive disorder is not made if the symptoms occur only during the course of the psychotic disorder, including residual phases. What about medical conditions that can make us depressed? Persistent depressive disorder must be distinguished from a depressive or bipolar and related disorder due to another medical condition. The way to do this is to assess for the presence of a medical condition that can cause depressive symptoms. Similarly, identifying whether or not a substance or medication is responsible for depressive symptoms follows a nearly identical line of reasoning. Here we assess as to whether or not a drug of abuse, a medication, or a toxin is etiologically related to the mood disturbance. If it is, then this is the diagnosis. And finally, let's differentiate persistent depressive disorder from personality disorders. This is another one of those situations where the patient needn't have one or the other. Here's a bit more on that. A personality disorder is characterized by an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture, with onset by adolescence or early adulthood. Personality disorders commonly co-occur with persistent depressive disorder. If criteria are met for persistent depressive disorder and a personality disorder, both may be diagnosed. Brianna is now confident that you have correctly identified the diagnosis of persistent depressive disorder, and now she would like to know how you plan to treat her mental disorder. And so, with safety in mind, how would you proceed with treatment in the case of persistent depressive disorder? In general, the treatment and management of persistent depressive disorder does not vary significantly from the treatment and management of a major depressive disorder. While there may be differences in the individualization of treatment plans based on symptom number, severity, and chronicity, the general principles of pharmacotherapy and psychotherapy remain the same. It is also commonly accepted and well validated that a combination of pharmacotherapy and psychotherapy is more effective than either treatment independently. If antidepressant therapy is indicated, it is probably safe to follow CANMAT guidelines for the treatment of major depressive disorder. Psychotherapy selection and type offered is less important than universal principles such as strong therapeutic rapport, but CBT and interpersonal therapy appear to be the most commonly studied for the treatment of depression. The Cognitive Behavioral Analysis System of Psychotherapy, CBASP, is a newer modality and the only psychotherapy specifically developed for the management of chronic depression, but it is yet to become the standard of care. Now to conclude Case 3. Brianna leaves the appointment with your management plan in mind. She remains low, but for the first time in a long time, feels a glimmer of hope that she won't always be depressed. Here is Case 4. Gloria, a 60-year-old woman, has been referred to you for assessment of anxiety. Past medical history is notable for hypertension, treated with ramipril, and obesity. She is married to Janice and has 3 adopted sons, ages 16, 18, and 24. In terms of psychiatric history, Gloria has never seen a psychiatrist before, but was treated for depression and anxiety from age 12 to 24, and again from 30 to 38. My symptoms have always had an odd presentation, she tells you. They seemed to come and go so frequently when I was younger, and I thought I was done with them for good around age 50. In fact, I went off of all psychiatric medications at that time. Now, the symptoms are back. One minute I'm crying, and the next I'm on top of the world, and I get so tense. I can't concentrate. I have no control. What's going on with me? On further history taking, you learn that Gloria has been taking hormone replacement therapy for the past several months. Keeping in mind this is a presentation on depressive disorders, what is your preferred diagnosis? And how would you confirm this diagnosis? This patient would be diagnosed with premenstrual dysphoric disorder, which is characterized by mood lability, irritability, dysphoria, and anxiety symptoms that repeat during the premenstrual phase and remit around onset of menses. Criteria require that a number of symptoms be present, and that they must be present for most cycles, at least 2 of which must have prospective ratings. To meet criteria, individuals must have at least 1 milk symptom and at least 1 ice caps symptom, but total symptom number must be at least 5. Milk stands for mood, irritability, lability, and keyed up. And ice caps stands for loss of interest, poor concentration, low energy, lack of control, loss of appetite, physical symptoms, and sleep problems. Unlike other conditions we've covered, PMDD may occur with other mental disorders. So, you think the other doctors that have seen me have been wrong about me struggling with depression and anxiety? No one has ever mentioned that my symptoms might have something to do with my periods. How common is this disorder? How come I experience this and Janice doesn't? Are there any risk factors for the condition that you can tell me about? What is the prevalence of premenstrual dysphoric disorder? And what are the risk factors for premenstrual dysphoric disorder? The 12-month prevalence of premenstrual dysphoric disorder is estimated at 1.3 to 5.8% of all menstruators. Biological risk factors for this condition include being a postmenarchal female or receiving hormone replacement therapy if you're postmenopausal, and family history. In fact, heritability is thought to be somewhere between 30 to 80%. Environmental risk factors for this condition include stress, interpersonal trauma, and seasonal changes, as well as sociocultural aspects of female sexual behavior and the female gender role. Okay, I think I trust you, but since the other doctors were wrong about my diagnosis, could it be anything else? Why or why not? What is the differential diagnosis for premenstrual dysphoric disorder? This is the differential diagnosis for premenstrual dysphoric disorder. How does premenstrual dysphoric disorder differ from premenstrual syndrome? Unlike premenstrual dysphoric disorder, PMS does not require a minimum of 5 symptoms, nor mood-related symptomatology, and it is generally considered to be less severe than PMDD. While premenstrual syndrome shares the feature of symptom expression during the premenstrual phase of the menstrual cycle, the presence of somatic or behavioral symptoms, without the required affective symptoms, likely meets criteria for PMS and not for premenstrual dysphoric disorder. What about dysmenorrhea? Well, dysmenorrhea is a syndrome of painful menses, but this is distinct from a syndrome characterized by affective changes. Moreover, symptoms of dysmenorrhea begin with the onset of menses, whereas symptoms of premenstrual dysphoric disorder, by definition, begin before the onset of menses, even if they linger into the first few days of menses. How does premenstrual dysphoric disorder differ from other conditions with depressive symptoms? Many females with bipolar or major depressive disorder or persistent depressive disorder believe that they have premenstrual dysphoric disorder. However, when they chart symptoms, they realize that the symptoms do not follow a premenstrual pattern. Because the onset of menses constitutes a memorable event, they may report that symptoms occur only during the premenstrual period or that symptoms worsen premenstrually. This is one of the rationales for the requirement that symptoms be confirmed by daily prospective ratings. The process of differential diagnosis, particularly if the clinician relies on retrospective symptoms only, is made more difficult because of the overlap between the symptoms of premenstrual dysphoric disorder and some other diagnoses. The overlap of symptoms is particularly salient for differentiating premenstrual dysphoric disorder from major depressive episodes, persistent depressive disorder, bipolar disorders, and borderline personality disorder. Let's consider hormonal treatments. Some women who present with moderate to severe premenstrual symptoms may be using hormonal treatments, including hormonal contraceptives. If such symptoms occur after initiation of exogenous hormone use, the symptoms may be attributable to the use of hormones rather than to the underlying condition of premenstrual dysphoric disorder. If the woman stops hormones and the symptoms disappear, then this is consistent with substance or medication-induced depressive disorder. You can probably guess how the differential of other medical conditions applies in this case. Women with chronic medical conditions may experience symptoms of premenstrual dysphoria. As with any depressive disorder, medical conditions that could better account for the symptoms should be ruled out, such as thyroid deficiency and anemia. I guess that makes sense. When you put it that way. So what are you going to do about it? With safety in mind, how would you proceed with treatment in the case of premenstrual dysphoric disorder, generally? Treatment for premenstrual dysphoric disorder can be divided into non-pharmacological and pharmacological treatments. Non-pharmacological treatments include regular exercise, diets low in salt and caffeine, supplementation with B6 and calcium, stress reduction, good sleep, and CBT. Pharmacological options relate to either hormones or serotonin. The best evidence is for droperidone, which is the only FDA-approved treatment for this condition. There is evidence for the use of standard treatments for depressive symptoms, including SSRIs, SNRIs, and even clomipramine. GnRH agonists can be used as a last resort treatment for premenstrual dysphoric disorder. And now to conclude Case 4. Gloria decides that she wants to continue with hormone replacement therapy despite the potential for ongoing symptoms of premenstrual dysphoric disorder. She decides to start exercising again and focuses on her diet. She joins a once-a-week yoga class and starts an SSRI to help manage symptoms. Now Case 5. You are a family physician and are about to see your patient Brian for the chief concern of depression. Brian's medical history is significant for ADHD, which was diagnosed in childhood, but never treated with stimulants due to parental concern with stimulant medications. Brian has been living transiently for the past 7 years after he dropped out of college. Since that time, he has been struggling to make ends meet and has been incarcerated on 2 occasions for assaults that occurred while under the influence of alcohol. A mental status exam, Brian is downcast and poorly kempt. He is not tearful, but sniffles frequently throughout your interaction. He tells you that he has abstained from alcohol for the past 6 months. He seems shaky, and you can hear his stomach growling. He tells you that he has been feeling depressed since waking up this morning and is experiencing suicidal ideation. Keeping in mind this is a presentation on depressive disorders, and what is your preferred diagnosis? And which substance or class of substances do you think Brian has been using? This is a case of substance or medication-induced depressive disorder. The essential feature of this disorder is the onset of depressive symptoms in association with the substance and persisting beyond the expected length of its effects. The criteria are prominent or persistent low mood or anhedonia, and evidence that this occurred following withdrawal or intoxication from a substance that can cause depressive symptoms. Here is a table displaying different substances that can cause depressive symptoms, secondary to either intoxication or withdrawal. These can be remembered with the mnemonic phrase, O sa pia cash. This stands for opioid, sedative, anxiolytic, hypnotic, phenylcyclidine, inhalant, alcohol, cocaine, amphetamine, stimulants, and hallucinogens. The specifiers for this disorder include with onset during intoxication and with onset during withdrawal. Brian is surprised to hear that you think substance use precipitated his depression, but is willing to discuss the diagnosis of substance or medication-induced depressive disorder further. What is the lifetime prevalence of substance or medication-induced depressive disorder? What is the prevalence of this disorder amongst those with alcohol use disorder or stimulant use disorder? It's just one number. And what are the risk factors for substance or medication-induced depressive disorder? The lifetime prevalence of substance or medication-induced depressive disorder is 0.26%. The lifetime risk of alcohol and stimulant-induced depressive episodes in alcohol use disorder and stimulant use disorder is 40%. Biological risk factors for substance or medication-induced depressive disorder include male sex, black race, family history of substance use disorder, history of major depressive disorder, history of drug-induced depression, and insomnia or hypersomnia. Temperamental risk factors include feelings of worthlessness, thoughts of death, and history of suicide attempts. Environmental risk factors include psychosocial stressors, interferon alpha, high-dose steroids or a high plasma concentration of steroids, efavirenz, high estrogen or progesterone content in OCP, stressful life events in the past 12 months, and a highest level of education equal to grade 12. Brian is relieved that he's not the only one who's experienced substance or medication-induced depressive disorder and identifies with several of the risk factors you've outlined for him. Nevertheless, he is somewhat hesitant to believe that his cocaine use has produced these symptoms. He asks, could this be anything else? What is the differential diagnosis for substance or medication-induced depressive disorder? Thankfully, the differential diagnosis for substance or medication-induced depressive disorder is relatively short. First, let's consider how substance or medication-induced depressive disorder differs from the depressive effects of substance intoxication and withdrawal. Depressive symptoms occur commonly in substance intoxication and substance withdrawal. A diagnosis of substance-induced depressive disorder should be made instead of a diagnosis of substance intoxication or substance withdrawal when the mood symptoms are sufficiently severe to warrant independent clinical attention. For example, dysphoric mood is a characteristic feature of cocaine withdrawal. Substance-induced depressive disorder with onset during withdrawal should be diagnosed instead of cocaine withdrawal only if the mood disturbance in criterion A predominates in the clinical picture and is sufficiently severe to be a separate focus of attention and treatment. How do we differentiate between depressive disorders that are substance or medication-induced and other depressive disorders? A substance or medication-induced depressive disorder is distinguished from an independent depressive disorder by the fact that even though a substance is taken in high enough amounts to be possibly etiologically related to the symptoms, if the depressive syndrome is observed at times other than when the substance or medication is being used, it should be diagnosed as an independent depressive disorder. Finally, let's differentiate between a substance or medication-induced depressive disorder and a depressive disorder due to another medical condition. Because individuals with medical conditions often take medications for those conditions, the clinician must consider the possibility that the mood symptoms are caused by the physiological consequences of the medical condition rather than the medication, in which case depressive disorder due to another medical condition is diagnosed. The history often provides the primary basis for such a judgment. At times, a change in the treatment for the medical condition, for example, medication substitution or discontinuation, may be needed to determine empirically whether the medication is the causative agent. If the clinician has ascertained that the disturbance is a function of both another medical condition and substance use or withdrawal, then both diagnoses may be given. When there is insufficient evidence to determine whether the depressive symptoms are associated with a substance, ingestion or withdrawal, or with another medical condition, or are independent, a diagnosis of other specified depressive disorder or unspecified depressive disorder is indicated. You have reassured Brian of your preferred diagnosis, and he has started to accept that cocaine use may underlie his depressive symptoms. He anxiously awaits your suggestions for treatment. With safety in mind, how would you approach treatment for substance or medication-induced depressive disorder, generally? The treatment of substance or medication-induced depressive disorder generally focuses on the resolution of the underlying substance use disorder or stopping the medication, if possible. Psychotherapy can be used, but it would be more focused on helping the patient to abstain from the depressive substance rather than depression itself, although this may also be helpful. Most antidepressants are safe, and these may be used in substance or medication-induced depressive disorder. Now to conclude Case 5. You refer Brian to addictions counseling and hold off on pharmacotherapy for now. Sometime later, he returns to your clinic, and despite abstinence from cocaine, he continues to experience depressive symptoms. You initiate treatment with an SNRI, and several weeks later his mood is improved. Eventually, he becomes an addictions counselor, marries, and moves into his own home. Satisfied with his progress in life, you initiate a stimulant medication to address his long-standing ADHD. He responds very well to this treatment and thanks you for giving his life back to him. Here's the next case. You are a medical student on call for psychiatry, and you've just been asked to see a patient presenting with the chief concern of depression. As the resident you are on call with is relaying this history to you, their pager goes off. They excuse themselves from your presence and return the page. Their face goes white as they speak on the phone. They tell you that they must go to the ward to manage an emergency and ask that you meet with the patient and review with them afterwards. On assessment, the patient is bundled up in excessively warm clothing, appears tired, and is overweight. They ambulate slowly and complain of weakness, depression, and constipation. They report poor concentration, fatigue, increased appetite, and anhedonia. They tell you these symptoms have been ongoing for the past 2 months. Keeping in mind this is a presentation on depressive disorders, what is your preferred diagnosis? And is there a unique specifier you could apply in this case? This is a case of depressive disorder due to another medical condition. As you can see, this diagnosis has quite a bit in common with substance or medication-induced depressive disorder. The essential feature of depressive disorder due to another medical condition is the presence of prominent or persistent low mood or anhedonia that is linked to a general medical condition. Many different medical conditions have been associated with the onset of depressive symptoms. Here's a mnemonic for fans of Harry Stack Sullivan to help remember some of the more common etiologies. Chumship time. This stands for Cushing's, hypothyroidism, MS, stroke, Huntington's, Parkinson's, and TBI. There are several specifiers used in cases of depressive disorder due to another medical condition. These are with depressive features, which applies if full criteria are not met for a major depressive episode, with major depressive-like episodes, which applies if full criteria are met except for criterion C for a major depressive episode, and with mixed features, which we will talk more about later. You review recent laboratory investigations and confirm the medical diagnosis of hypothyroidism. You review with your resident and discuss next steps for this patient's care. Before heading back to the patient with your resident, in order for them to lay eyes on them, they smirk and ask you, what is the prevalence of depressive disorder due to another medical condition, and what are the risk factors for this condition? What is the prevalence of depressive disorder due to another medical condition? And what are the risk factors for depressive disorder due to another medical condition? Unfortunately, the epidemiology of this diagnostic label is not well understood, and due to the myriad of disease states that can lead to depressive symptoms. Biological risk factors for this condition include, obviously, having been diagnosed with a condition that can cause depressive symptoms. What? The emergency physician says to you when you tell them that hypothyroidism is to blame for the patient's presentation? But they're so depressed. There's no way this is just their thyroid acting up. Could it be anything else? Prove it. What is the differential diagnosis for depressive disorder due to another medical condition? This is the differential diagnosis for depressive disorder due to another medical condition. This first differential diagnosis is quite ambiguous. Essentially, we need to understand how depressive disorders due to another medical condition differ from other disorders in DSM-5-TR. Determination of whether a medical condition accompanying a depressive disorder is causing the disorder depends on a few factors. Number 1, the absence of a depressive episode prior to the onset of the medical condition. Number 2, the probability that the associated medical condition has a potential to promote or cause a depressive disorder. And, number 3, a course of the depressive symptoms shortly after the onset or worsening of the medical condition, especially the depressive symptoms remit near the time that the medical disorder is effectively treated or remits. Next, how do we differentiate between depressive disorder due to another medical condition and medication-induced depressive disorder? In these cases, the depressive symptoms are felt to be due to a medication and not a general medical condition. Here an important caveat bears mentioning, and that is that some medical conditions are treated with medications that can induce depressive or manic symptoms. In these cases, clinical judgment, based on all the evidence in hand, is the best way to try to separate the most likely and or the most important of the two etiological factors. Now let's see how delirium and major or mild neurocognitive disorder figure into this differential. A separate diagnosis of depressive disorder due to another medical condition is not given if the depressive disturbance occurs exclusively during the course of a delirium. However, a diagnosis of depressive disorder due to another medical condition may be given in addition to a diagnosis of major or mild neurocognitive disorder if the depressive disturbance is judged to be a physiological consequence of the pathological process causing the neurocognitive disorder and if symptoms of depression are a prominent part of the clinical presentation. What about adjustment disorders? It can be hard to adjust following the diagnosis of a medical condition, so how do we tell these apart? Here, the DSM-5-TR is not very helpful. They tell us that it is important to differentiate a depressive episode from an adjustment disorder, as the onset of the medical condition is in itself a life stressor that could cause depression. Some people become demoralized when facing a life-changing illness. How do demoralization and depressive disorder due to another medical condition differ? Demoralization is a common reaction to chronic medical illness. It is marked by a sense of subjective incompetence, helplessness, and hopelessness, and a desire to give up. It is often accompanied by depressive symptoms such as low mood and fatigue. Demoralization typically lacks the anhedonia associated with depressive disorder due to another medical condition, and individuals will generally find pleasure in previously meaningful activities and be able to experience moments of happiness. Okay, the emergency physician concedes, I guess it could be hypothyroidism. But I still think this is a psychiatry thing. How can we treat this patient? With safety in mind, how would you approach treatment for a patient presenting with depressive disorder due to another medical condition? Generally. So how do we treat depressive disorder due to another medical condition? The treatment of depressive disorder due to another medical condition is much the same as treating depressive symptoms due to another cause. In terms of pharmacotherapy, we use standard antidepressant treatments with, perhaps, more consideration for medications used in the treatment of medical conditions that might interact with our psychopharmacological armamentarium. Psychotherapeutic interventions follow psychoeducation and CBT. Now to conclude Case 6. Once the patient's hypothyroidism is treated, they return to euthymia. The emergency physician you interacted with never refers a patient for depressive disorder due to hypothyroidism ever again. Next, let's consider cases 7 and 8 in parallel. It is a typical night on call, and so far you've had 7 consults. Feeling tired, but determined to persevere, you work steadily into the early hours of the morning. Around 0500, your pager goes off. You return the page, and your attending tells you about 3 more consults. One consult, you decide to leave until the morning for a review by the day team, but you are pressured into seeing the other 2. Just get the bare minimum, your attending tells you. Just enough to know in or out and what treatment to start. The specific diagnosis isn't as important to me right now. I know it's late. Here's the first patient. Stephen is a 34-year-old male presenting with depression, with onset of 6 days ago with no obvious trigger. He reports poor concentration, anhedonia, sleep disturbance, poor appetite, and daytime fatigue. And here is the second patient. Taylor is a 45-year-old non-binary individual presenting with depression. When you see them, it is 0730, and handover is scheduled for 0800. You know your time is limited, and you need to rush the interview to get through it in time. You find Taylor to be suicidally depressed and tearful. You are unable to engage them in safety planning and decide to admit them to hospital. The information provided is limited, but your staff is happy with your decision and you decide to put off treatment planning to the inpatient team. In the case of Stephen, our 34-year-old male presenting with depression, what is the most likely diagnosis? And in the case of Taylor, our 45-year-old non-binary individual presenting with depression, what is the most likely diagnosis? Cases 7 and 8 relate to the diagnoses of other specified depressive disorder and unspecified depressive disorder, respectively. In other specified depressive disorder, the patient presents with symptoms of a depressive disorder that result in dysfunction, but which do not meet criteria for any of the other disorders we've reviewed so far. And you choose to say why. Here is one example. If you had a patient that presented with symptoms meeting criteria for major depressive disorder that had been present for an interval less than 2 weeks, the diagnosis could be other specified depressive disorder, short duration depressive episode. What about unspecified depressive disorder? Well, the first 2 points remain the same. Where unspecified depressive disorder differs from other specified depressive disorder is, you guessed it, instead you choose not to say why the patient does not meet the criteria for another depressive episode. This includes situations in which there is insufficient information to make a more specific diagnosis, such as when you were stuck in the emergency department at 7:30 a.m. Now let's conclude cases 7 and 8. Stephen is agreeable to outpatient planning. You start an antidepressant and discharge him home with plans to follow up with his family physician. Taylor is admitted, and the diagnosis is eventually clarified as major depressive disorder, severe, with mood-congruent psychotic features. They are started on a first-line treatment for major depressive disorder, as well as aripiprazole. They eventually respond to medication and start CBT on an outpatient basis. This slide serves as a summary for the disorders we've covered so far. To review, I will state the name of the disorder and its essential feature. The essential feature of disruptive mood dysregulation disorder is chronic and persistent severe irritability. The essential feature of major depressive disorder is a period of at least 2 weeks during which there is depressed mood or loss of interest or pleasure in nearly all activities, and in children this extends to irritability. This symptom is accompanied by 4 other M-SIGI-CAP symptoms or signs. The essential feature of persistent depressive disorder is depressed mood most days, most of the time, for 2 years, or 1 year in kids whose mood can also be irritable. The essential feature of premenstrual dysphoric disorder is mood lability, irritability, dysphoria, and anxiety symptoms that repeat during premenstrual phases and remit around the onset of menses. The essential feature of substance or medication-induced depressive disorder is the onset of depressive symptoms associated with the substance, during or soon after, for example, up to 1 month, and persisting beyond the expected lengths of its effects. The essential feature of depressive disorder due to another medical condition is the presence of prominent or persistent low mood or anhedonia that is linked to a general medical condition. The essential feature of other specified depressive disorder is symptoms of depressive disorder that lead to dysfunction and you choose to say why. For unspecified depressive disorder, the essential feature is symptoms of a depressive disorder that lead to dysfunction and you choose not to say why. Now let's move on to Part 2, where we'll discuss specifiers relevant to the depressive disorders chapter. Here is Case 9. Eric is a 45-year-old male admitted to the inpatient unit with the diagnosis of major depressive disorder. He has experienced 3 weeks of low mood, anhedonia, insomnia, increased appetite, poor concentration, and daytime fatigue. On mental status examination, he is tearful and poorly count. Eric reports passive suicidal ideation and is currently unable to work due to his symptom burden. How severe is Eric's major depressive disorder? Severity is based on the number of criterion symptoms, the severity of those symptoms, and the degree of functional disability. To qualify for a depressive disorder of mild severity, few, if any, symptoms in excess of those required to make the diagnosis are present. The intensity of the symptoms are distressing, but manageable, and the symptoms result in minor impairment in social or occupational functioning. To qualify for a depressive disorder of severe severity, the number of symptoms is substantially in excess of that required to make the diagnosis, the intensity of the symptoms is seriously distressing and unmanageable, and the symptoms markedly interfere with social and occupational functioning. To qualify for a depressive disorder of moderate severity, the number of symptoms, intensity of symptoms, and or functional impairment are between those specified for mild and severe. Now for Case 10. You were a third-year psychiatry resident teaching a group of medical students the art of interviewing patients with mental disorders. Brittany, a 28-year-old female, has volunteered to be interviewed. Although she was previously diagnosed with major depressive disorder, she tells the interviewer that she has not experienced symptoms of major depressive disorder for the past 6 weeks. What is Brittany's current remission status? When someone is in remission, we use the specifiers in partial remission and in full remission. In order for the patient to be considered in partial remission, symptoms of the immediately previous major depressive episode are present, but full criteria are not met, or there is a period lasting less than 2 months without any significant symptoms of a major depressive episode following the end of such an episode. Whereas, being in full remission means that during the past 2 months, no significant signs or symptoms of the disturbance were present. So with that said, to differentiate between partial and full remission, consider the signs and symptoms that have been present over the past 2 months. Now for Case 11. Greg is a 54-year-old male referred to you for assessment of anxiety. He relays the following history: 6 weeks of low mood, anhedonia, poor concentration due to worry, hypersomnia, fatigue, restlessness, poor appetite, feelings of hopelessness, and an overwhelming fear that something awful may happen. What is the most likely diagnosis in this case? Here, the diagnosis is major depressive disorder with anxious distress. In order to remember the symptoms and signs needed to qualify for this diagnosis, the mnemonic KFCR can be used. This stands for Number 1, feeling keyed up or stressed. Number 2, fear something awful may happen. Number 3, fear of losing control. Number 4, concentration poor due to worry. And number 5, restlessness. 2 of which must be present to apply the specifier. Because anxiety is an important prognostic indicator in major depressive disorder, we can further specify the severity of anxious distress. With mild anxious distress means that only 2 of KFCR are present. Moderate anxious distress means that 3 of KFCR are present. Moderate to severe anxious distress means that 4 to 5 of KFCR are present. And finally, with severe anxious distress means that 4 to 5 of KFCR are present, along with motor agitation. Now for case 12. Andrew has been depressed for the past 4 weeks and meets criteria for an index episode of major depressive disorder. However, over that same time period, he also endorses increased goal-directed activity, sexual indiscretion, which is out of character for him, and reduced need for sleep. These symptoms occur most days, most of the time. What is the most likely diagnosis in this case? The diagnosis in this case is major depressive disorder with mixed features. In order to qualify for this course specifier, 3 of the following symptoms must be present most of the day, most of the time during the major depressive episode. Number 1, elevated or expansive mood. Number 2, grandiosity. Number 3, goal-directed activity increased. Number 4, flight of ideas. Number 5, indiscretion. For example, increased sexual behavior or pleasureful activities with painful consequences. Number 6, sleep not needed. And number 7, talkativeness. To remember these symptoms, I use the mnemonic egg fist. These symptoms must be noticeable by others. To remember this caveat, I added the word Bach to my egg fist mnemonic. This stands for behavior equals observable change by kin. The last thing I'll mention here is that mixed features associated with a major depressive episode have been found to be a significant risk factor for the development of bipolar I or bipolar II disorder. As a result, it is clinically useful to note the presence of this specifier for treatment planning and monitoring of response to treatment. Now for case 13. Nothing phases me anymore, the patient tells you. I'm not eating, I've lost weight, and I hate waking up in the morning, as this is when symptoms are worst. I wish I could sleep all day, but I find I'm always waking up 3 or 4 hours before my alarm goes off. I just lay there. I'm so depressed. It's been months. Will this ever go away? I'm hopeless. What is the most likely diagnosis in this case? The diagnosis in this case is major depressive disorder with melancholic features. Melancholic means there is a near complete absence of the capacity for pleasure, not just a minor reduction. Even highly desired events are not associated with marked brightening of mood. Either mood does not brighten at all, or it brightens only partially. Psychomotor changes are almost always present and observable by others. Melancholic features have only a modest tendency to repeat across episodes in the same individual. Major depressive episodes with melancholic features are more frequent in inpatients as opposed to outpatients, and more likely to occur in cases with psychotic features. To meet criteria for the melancholic features course specifier, patients must have 3 excessive dumps. This mnemonic stands for excessive guilt, depressed mood, underweight, either not eating or weight loss, morning worsening of mood, psychomotor change, and sleep worse in the morning, that is, waking at least 2 hours earlier than expected. Now for case 14. I feel so heavy lately, and nobody likes me. I used to love my job. I was a model employee, but everyone was envious of me. Since the demotion 2 months ago, it's clear to me that they never really appreciated me. All I do is eat all day or sleep. There's nothing for me to do. There's nothing I enjoy anymore. Every day is the same thing over and over again. I hate this feeling. Why am I so low? I just can't focus on anything. What is the most likely diagnosis in this case? The diagnosis in this case is major depressive disorder with atypical features. The mnemonic for this course specifier is Mr. 2 Ailes. That is, individuals with atypical features retain the capacity to be cheered up when presented with positive events, i.e., mood reactivity. In addition, they endorse at least 2 of the following Ailes symptoms: appetite increased, or weight gain, interpersonal rejection sensitivity, leaden paralysis, that is a heavy feeling in the extremities, and sleep increased, hypersomnia, sleeping for 10 or more hours per day. Understandably, individuals with the atypical features specifier cannot also receive the melancholic or catatonic features specifier during the same episode. Now on to case 15. Barry has been struggling with major depressive disorder for the past 7 years, with first episode onset shortly after his 20th birthday. Today he presents to the emergency department with his typical depressive presentation, that is low mood, loss of pleasure, poor concentration, fatigue, and insomnia, with the addition of the conviction that he is already dead, a corpse, a pointless, useless member of the Walking Dead. He reports auditory hallucinations, which chastise him for having lived a pointless life. What is the most likely diagnosis in this case? This is major depressive disorder with mood-congruent psychotic features. Now, what do we mean by mood-congruent? Mood-congruent refers to the presence of delusions or hallucinations consistent with typical depressive themes of personal inadequacy, guilt, deserved punishment, death, nihilism, and disease. These themes can be remembered with the mnemonic pig den disease, which stands for personal inadequacy, guilt, deserved punishment, death, nihilism, and disease. What about mood incongruent features? In this case, delusions or hallucinations would not involve typical pig den disease themes that we may typically see in depression. Now for case 16. Ryan, a 24-year-old transgender man, presents to your office 3 weeks postpartum after delivering twin girls, Anna and Sophia, with the chief concern of loss of pleasure and interest. He endorses symptoms consistent with a major depressive episode and clarifies that they began soon after delivery with baby blues that just didn't go away. What is the most likely diagnosis in this case? How common is this disorder? And what are the risk factors for this disorder generally? The diagnosis in this case is major depressive disorder with peripartum onset. To qualify for this course specifier, a patient must have onset of depressive symptoms either during pregnancy or within the first 4 weeks postpartum. The incidence of this disorder is 3 to 6%, with 50% of individuals presenting with symptoms during pregnancy. Risk factors include being premiparous, previous postpartum mood episode, a history of a mood disorder, family history of bipolar disorder, and psychological factors including psychosocial adjustment to parenthood. Case 17. You are a psychiatrist working at the Student Wellness Center. It is a cold winter's day, and you are about to meet your last patient before heading home to your cozy apartment. Brandy is a 19-year-old female referred for assessment of depression which is worse in the winter months, improves in the summer, and is associated with increased sleep, increased energy, and increased appetite, particularly for carbohydrates. Sight unseen, what is the most likely diagnosis in this case? This is a case of major depressive disorder with seasonal pattern. To meet criteria for this course specifier, the patient needs to have at least 2 major depressive episodes over the past 2 years which coincide with the same season. Between episodes, individuals' depressive symptoms remit. And for individuals who have both seasonal and non-seasonal episodes of depression, the number of episodes that occur in a predictable pattern, that is, in the same season, must outnumber non-seasonal episodes. Common symptoms seen in individuals with a seasonal pattern can be remembered with the mnemonic CHEW. This stands for carbohydrates, hypersomnia, energetic, and weight gain. The most common pattern is depressive episodes occurring in fall or winter with resolution in the spring. The prevalence of individuals with seasonal pattern positively correlates with latitude. Young people have greater risk for winter depressive episodes compared to older people. Now case 18. You are on call in the emergency department when you receive a consult for BN, a 34-year-old male with past psychiatric history notable for depression. The emergency medicine physician describes BN as floridly psychotic. On assessment, BN is mute, grimacing, and echopractic. Collateral history notes that BN has been suicidally depressed for the past several weeks after the prescriptions for lithium and fluoxetine were discontinued quickly and without warning by their family physician. What is the most likely diagnosis in this case? This is major depressive disorder with catatonia. The catatonia specifier can apply to an episode of depression if catatonic features are present during most of the episode. The mnemonic used to remember these symptoms is Camp W. Gaines, of which you require 3 symptoms in order to meet criteria for this specifier. C stands for catalepsy. This is the passive induction of a posture held against gravity. A stands for agitation. Here, we are talking about agitation not influenced by external stimuli. M stands for mutism. Mutism is no or very little verbal response, and it is not applicable if the patient is aphasic. The second M stands for mannerism. Mannerisms are odd, circumstantial caricatures of normal actions. P stands for posturing. Posturing is spontaneous and active maintenance of a posture against gravity. W stands for waxy flexibility. Waxy flexibility is slight, even resistance to positioning by the examiner. G stands for grimacing. This one is self-explanatory. E stands for echolalia. Echolalia is mimicking another's speech. The second E stands for echopraxia. Echopraxia is mimicking another's movements. N stands for negativism. Negativism is opposition or no response to instructions or external stimuli. S stands for stupor. Stupor represents minimally reactive and dull behavior. The second S stands for stereotypy. Stereotypies are repetitive, abnormally frequent, and non-goal-directed movements. This slide serves as a summary for the various specifiers we've just discussed. For review, I will name them and give a brief description of each. Occurrence severity. The severity of a depressive episode depends on the number of symptoms, individual symptom severity, and level of impairment. Severity can be classified as mild, moderate, and severe. Remission status. Patients may be in partial or in full remission depending on criteria met over the preceding 2 months. Individuals in partial remission may present with one of two situations. They may have some symptoms, but no longer meet full criteria for a major depressive episode, or they may have no depressive symptoms for less than 2 months. To qualify for full remission, individuals must have had no signs or symptoms of depression for at least 2 months. With anxious distress. To qualify for this specifier, individuals must have at least 2 of the KFCR symptoms. That is, feeling keyed up, fear of losing control, fear that something awful may happen, loss of concentration due to worry, and restlessness. Given the relationship between anxiety and suicide, anxious distress is further specified in terms of severity. With mixed features. This requires that at least 3 egg fist symptoms are present and observable by others. This stands for elevated mood, grandiosity, goal-directed activity, flight of ideas, indiscretion, sleeplessness, and talkativeness. With melancholic features. This requires anhedonia or loss of emotional reactivity along with 3 excessive dumps. That is, excessive guilt, depressed mood, underweight, morning worsening of mood, psychomotor change, and sleep worse in the morning. With atypical features, requires mood reactivity along with 2 of appetite, increased, interpersonal rejection sensitivity, leaden paralysis, and sleepiness. With mood-congruent psychotic features, that is, delusions or hallucinations related to typical depressive themes of personal insufficiency, guilt, deserved punishment, death and disease, and with incongruent psychotic features, that is, any delusion or hallucinations not related to typical depressive themes of personal insufficiency, guilt, deserved punishment, death and disease. With peripartum onset, which relates to a major depressive episode that occurs either during or within 4 weeks following delivery. With seasonal pattern, in which there are recurrent major depressive episodes that correspond to a particular season with expected onset and remission of the symptoms, and chew symptoms, that is, carbohydrates, hypersomnia, energetic, and weight gain. And finally, with catatonia. This requires the presence of 3 of the 12 Camp W. Gein's symptoms of catalepsy, agitation, mutism, mannerisms, posturing, laxiflexibility, grimacing, echolalia, echopraxia, negativism, stereotypy, and stupor. This brings us to the end of the presentation. Thanks for your attention. I'm David Patrician.